We are ready to go. So I would like to present to you Dr. Marcia Perretto.
All right, so officially done online. So hello everyone. Hello everyone online. Everyone here, welcome. Thank you for coming. It's my first time doing a presentation like this, so I'm sure I'm gonna have hiccups, brain fog, and um, hope I can, if you, all of you that are online or in person, can leave here today with one little thing that can help you in your journey. I will feel like I have done my job today. So I hope I can give you one nugget that you guys can take home with you today. Okay. So what I did is I created a little bit of a timeline, and here I go, clumsy as I can be. I created a little timeline that I wanted to use, so I remember everything I want to talk to you guys. So how many of you actually knew me from before? Have you anyone has heard about me? You did. Uh, you heard about me. Okay, hope good thing. So a little bit of my journey. I did not know any of this. Uh, went to school with the traditional education, struggled most of my life with a bunch of symptoms that I didn't know what they were. I just thought I wasn't trying hard enough. So I kept trying. And in the process of trying a little harder, I kept on overusing my body and getting through more and more trouble. Um, through a lot through a lot of bumps on the road, I end up becoming severely ill. So in a nutshell, I had my daughter, which ended up causing a lot of issues during labor and delivery. No surprise there. Then complications just stayed. Of course, it wasn't challenging enough to have an infant. I decided to do my doctorate degree along with an infant. So it was a challenging 5.5 years. Took me a little while to complete. Um, and then I decided that because I used to be a figure skater, right? So, oh yes, and I had a Russian coach, which makes it even more destroying to the body, right? So I always had the mindset that I can do it. I just have to try harder. And so once I was finishing on my doctorate degree, I just figured that I go back training. I can do this. And I kind of goes back a lot, actually. So if you really stop and think, it was a lot. I ended up injuring my hip, orthopedic injury, nothing big deal. I went running, slip on sand, my hip popped. I was feeling my joints already wobbly. I didn't know why. My fatigue was higher. Didn't know why. I just thought it was the condition. End up having surgery because we couldn't rehab. Surgery failed right away. My surgeon didn't know why. Everyone gets better. Why you didn't? It might be that you have something going on because when I got my blade and I go in and I press down and you just stretch far and then you just break under the knife instead having a tug. It might be your collagen. So I'm in bed, lying down, nothing else to do. Um, get my computer and do my first Google search. Genetic disorders. He said, I think it's genetic. So genetic disorders of collagen fiber. That was my first Google search. And I start going into the research part. Okay, what is this? Let's read some blogs. Let's read this. Let's read that. Came across connective tissue disorders, start learning about them. In the process, the years went passing. I didn't get better. End up with 2 more hip surgeries and end up disabled. I couldn't really walk much. I was within the house, POTS, mast cell, psychological, emotional, medical trauma, because how come you are not getting better? Everyone does, right? And heard everything possible, right? You're milking the system. I was like, yeah, the dream of my life. I spent a fortune getting a doctorate degree, And now I am disabled on a wheelchair, making half of my paycheck. Just my dream. So I was like, I had to take charge of it. And obviously, each one of us is very different. I didn't know anything about mast cell. I didn't know anything about POTS. I just knew I had symptoms that didn't match the traditional symptoms for everyone else. So I started rehabbing with what I knew in musculoskeletal and fail and try something else and fail and then try something else. And oh, that one works. And start exploring what would work for me, right? Doesn't work for you, doesn't work for you, may work for you, may not work for you, may work halfway for you, and there we go. We're all very different. So I found what worked for me. And in the process, then I started learning what was mast cell. I started learning what was POTS. Um, and I realized that we don't learn these things in school. And I realized that not only PTs don't learn this in school, but physicians don't learn this in school. And OTs don't learn this in school, and no one learns this in school after all, right? So with that being said, it took me to get what I am today, 12 years. I started with walking a block. I mean, actually started by going downstairs, honestly, because I had to get out of my bedroom. So for me, a challenge was just that. Have you guys heard that song, A Stairway to Heaven? Yeah, that's what it looked like every time I had to go up again. I'm like, oh Lord. Um, and then getting out, going to the front of my garden, and then being able to walk a block, and then being able to, little by little, finding my path to health. Still didn't know what POTS was, just thought I was dizzy because I was deconditioned. Still didn't know what mast cell was. It all started making sense as I started rehabbing. And I started researching. And in this 12 years, I went from being able to not even barely get downstairs and upstairs. And again, this is not for everyone, okay? Doesn't mean that everyone has to be or ever want the same goal I wanted. I was an athlete. I was a figure skater. I was a horseback rider. I was a competitive barrel racer. If you guys know what horse barrel racing is, yeah, I did that. So from from that to nothing is emotionally traumatizing too. Right? And then there is that too, right? Your emotions are in pieces. It affects everyone around you too, not only you, right? It hits your family, I mean, I had a toddler, right? So it affects everything. With that, on this 12 years journey, each year I have been able to take up a new activity. And I kind of decided I was going to break all my own barriers, which is not for everyone again. So now I am to a point where I row about 20 miles a week. I cycle about 20 to 30. I run, which I shouldn't. Don't let my surgeon listen to this. I do wish him every year. I wish him happy hip anniversary. I call him every September, happy hip anniversary, because I have 3 hip surgeries by the same surgeon. So we have to celebrate. I do jog run, shouldn't, but again, I break it, I fix it. It's not for everyone, right? I am a country line dancer and a country swing dancer, about 3 hours every Saturday. So I've been each year picking up a new activity and enjoying it. If you ask me, do you still have symptoms? If my immune system drops, I will feel my POTS will will come up, my toes will get cold, my certain foods will trigger an immune reaction. But I learned to have fun in the process, and I started focusing on what I enjoy and what makes me happy. And I didn't let all those labels that
Marcia, we can't hear you. Marcia, we can't hear you.
But they are also dependent on the environment you are, on the support you have, on our histories, right? All the traumas we went through, and and the traumas we had, the traumas we earned trying to visit different providers and being discredited or being, and sometimes it's even because they just haven't ever been told what that was. But I think we have to just move on, because if we let those things affect us, it's only going to pull us down even further. And I have learned that if we forgive, right? If we forgive them and move on, because it's not going to do any good to us if we just keep carrying it, we're going to encounter a million providers that will push us away. We're going to encounter in different areas of the healthcare, different family members, different environments in church, anywhere. So I think we just like, oh, you don't want to understand this? Oh, well, next, right? It's easier to talk about this now. It wasn't easy to talk about this in the past. So I think with this many years of doing this, I made my mission to understand how it affects each one of us and how it affects each one of us in different moments of our lives too. Because there are moments of our lives we're stronger, we have better support, we have things are doing better. It's one thing. And then in a moment of our lives where we are more vulnerable, something has happened, because it does happen, right? Things will happen, life events, losing someone we love, whatever that is, it's going to make us more vulnerable, and that might make us more prone to maybe flare a symptom, and that is different than on the flare that you had when you had an injury, right? That is different when you first found out that you had something wrong with your collagen, right? There are only 260 plus different types of connective tissue disorders. It's very easy to find which one it was. Like collagen with two L's or one? Wait a second. So that being said, what I started looking at as I developed my practice and whatever like I always say, I don't have a protocol, because having a protocol means that I have a round hole and each one of you has to be a round peg that has exactly the same measurements to fit in that hole. And unless you are all made out of the same cut, no one is gonna fit here, right? And the chances that is really small. So I learned that when I sit down with you guys, and this has come from my associations and conversations, I have been reaching out to physicians and institutions all over the United States and even around the world. Sometimes get blocked, ignored. I don't care. Move on. You guys gonna come after me one day. Just kidding. But like going after people and trying to understand, okay, what are you guys doing for this? What are you seeing? How is your patient population different from the one I see? And how can we partner and make this whole thing stronger and better for the patients, and for each one the experience. So if someone has mast cell, POTS, and EDS is one thing, but if you have mast cell and EDS and some other type of thing, you know, it's a whole different story. And sometimes we don't even know we have something, right? We just know we don't feel good. And we're trying to hunt for a diagnosis. So what is being done? And is the diagnosis really it's important, yes, but are we are you guys, you can see me all right? Okay. Um, the diagnosis is important for peace of mind, but we have to be careful not to identify so much with it that we lose our North Star, right? Because then when we are told we have a connective tissue disorder that is genetic, and there is nothing that can be done because it's genetic. And then we like, oh, wait, I just went from having all the hope to being like, oh, I got this thing that never goes away now, right? So if life gives you lemons, let's make a lemonade, right? So, and I add ice and I put some mint leaves in it and let's party. So I went after like different, like I associated with Mayo, I associate with Hopkins. I am part of a masterminds group that is all about masterminds. Does that hint you anyway? So it's about mast cell activation syndrome and Stostow's immune system and all that. And I just started associating to different professionals and picking brains because it's great to say that physical therapy is the thing that's gonna be your best friend for the rest of your life. But how can we make that physical activity? Let's not talk PT. Let's not talk PT. Let's not talk OT. Let's not talk, you know, specific specialties. Let's talk healthcare, right? How can we unite power to empower each one of us to get better, right? And we are not a musculoskeletal system, and then an immune system, and then a cardiovascular system, and then whatever system, it's easier. And then we also have the spiritual side, and we have the emotional side, and the psychological side, and we have all those things that make us a whole. And then we are only treating one thing. Or each one of us in healthcare picks one part. Hey, I only do this. And then no one talks to no one. Right? So you get that piece of paper and that says, or you're the proud you're the proud owner of a big binder with a bunch of diagnoses, lots of handouts, and here you go. Right? But no one spoke to no one. And get someone or get a system where we can get all those printouts to the hands of someone that is going to really coordinate your care and look at how exercise affects your mast cell, how exercise affects your POTS, how POTS affects your exercise, how mast cell can make your exercising worse. Oh, but I got this cranocervical hypermobility slash CCI slash label, right? And how do you rehab all this and how that affects this one, which affects that one, which gives you that medication that causes that. And no one is going through that paperwork and saying, wait a second, this symptom could be this and this and that. So how are we going to get this and facilitate in a way that we get, let's go back to exercise, because at the end of the day, it's moving that makes us better, right? Because initially, not moving feels good until it doesn't. Been there, done that, right? That mattress is awesome until it's no longer comfortable, right? So figure out having someone coordinate your care, look at your entire history, right? Where is your emotional health right now? Where is your support system in a home? Where is your financial system support? Because it becomes expensive. Where is, are your physicians communicating? Is your PT really understanding how the POTS affects your physical activity and things like that? So being able to get someone that looks at the whole system and then looks at you as an individual, because it doesn't matter how that system goes. And if I try to treat you like I treat her, like I treat anyone at home, it's not going to work. I mean, maybe, but maybe not. And listen to each one of you. And that's why I vouch so much for the holistic approach, because if we don't have everything in place, if someone, like I have had patients come to my doors and say, well, I am saving on the food now because I need to buy my medicine and I need to pay. I'm like, if you're not eating, you're not nourishing. If you're not nourishing, you can't get better. Or I can buy that medication because it's so expensive, so I can't take it. But if you're missing out on a piece, a critical component, so how can we eventually create a movement where healthcare is going to look at us as a whole person instead keeping us sick, empowering us to get better? So that was my goal with associating with so many different, or reaching out to so many different important institutions everywhere, and try to learn as much as I can. And hopefully, eventually, this becomes something even bigger and nicer. If some of us have cranocervical instability, but then, or hypermobility to the and we all have to the entire spine, let's face it, right? The whole spine is hypermobile. We might have segments that might not be moving enough because others are moving too much. But how can we make this right for you? Maybe you can do this upright, but maybe you have to be reclined with the head supported, right? Maybe you can do a full turn, but maybe you can only turn a little. Maybe I can treat directly to more up, close to the neck. Maybe you have to start from the foot up. What is your need? And we need to look at each one of us that way. And I think that's where we have been missing as clinicians. I feel like I fail maybe a little less, tiny bit, than everyone else. But I don't know much more. I just guess research a little more, try to understand this a little more, maybe living in a body that sometimes decides that, no, I have a plan for you today. You have that big agenda? Great. Watch me. Right? It's one of those. But I feel like when I took so for me, in my personal experience, that's me. It's not you, not you, not you, no one. Okay. When I stopped associating myself to the diagnosis and I started looking forward to what I wanted to be and what I wanted to claim back into my life, and I started working literally my brain out of that trauma that I acquired from being ill and losing a lot of things in my life, including my marriage, full disclosure. I realized that I wanted more for me, and I wanted to be able not only conquer that for myself, but how can I make this better for everyone, right? So when I get at someone at the clinic, the way I see this is we sit down and we talk for about an hour and a half. I mean, sometimes you guys don't sit down. Sometimes you're lying down, sometimes you're standing, sometimes you're walking the room, and I'm just kind of going because I always say, if you can't sit for too long, get up and walk. If you can't be up, lie down. I don't care. Been there, done that. So I understand if you need to be up, if you need to take a break. I understand if it becomes emotional. I understand if we touch on a subject that might lead you to break down because been there, done that again, nothing is new, right? So I want to know your story. I want to know, and I think that's what we all should be looking as clinicians. How was your childhood? Were you sick? Were you healthy? Were you healthy until you're not healthy? When did that hit? Did you have any viruses, bacterial issues? Were you exposed to mold? Were you exposed to mercury? What was going on in your life? Because all this makes a difference, right? So let me learn about you. Let me learn the things that you like, the things you have to give away or give up, right? Things you had to give up, things you enjoy that you can no longer do. Because based on those things is where we are going to create a goal, right? This goal comes for you, not for me. I don't look at you and say, oh, you're gonna run 15 miles. Oh, you're cycling. I just decided today you're doing cycling. It's like, what do you want to accomplish? And it's not about the ultimate goal, it's about the milestones, right? Because sometimes we're so focused on where we're going to get that we forget to enjoy the ride. We forget to enjoy the journey. And I think the journey for me has been the most fun part of the whole thing as a clinician and as a patient, because I have been able to look back and say, wow, those stairs look a lot taller when I couldn't climb them. Now I climbed every 2 steps and I go upstairs and I have 3 floors. Sometimes I really wish I had an elevator. I get home, I'm like, ah, I gotta go up. But that's because I just came back from a run. I came back from cycling. So it's a different. But one day I look up those stairs and I had just come back from my couch. I got up from the dining room and those stairs look really, really difficult. So what is your goal? We created together. And what are the milestones, right? So what couldn't you do 3 months ago that now you can? Give yourself some credit. But sometimes we're so hard on ourselves. So we have to put these plans together because for you guys, it's hard to see. For all of us, for me, it was hard to see because all I could see is like, I cannot get on a horse. And I'm a big horseback rider. I cannot get on a horse. How am I going to swing my leg? My hip's tight. I cannot even get my leg over. And now I do. So how am I going to get there? And what are the small steps that I have to accomplish to get there, right? If you want to get upstairs, but you want to be able to, it's 16 steps, maybe you need to climb the first 3 or 4 without assistance, and then someone else jumps in and helps you throughout the rest of it. And then after that, you're able to do halfway, and after that, or you're going outside, or you can only do 2 repetitions of an exercise. Forget about 3 sets of 10. Who labeled that to have to be 3 sets of 10? Where did that come from? We just picked a number and we made it 3 sets of 10. But I have patients that starts with 3 sets of 1. Does that sound familiar? 3 sets of 1. Breaks that could last up to a minute and a half. That emotional aspect that hits you when you do something that you couldn't do before, or the fear that hits you when you have to do something that you have not been able to do. And we have to work that. So do we need brain training? Do we need a nutritionist? Do we need acupuncture? Do we need loud music with a nice playlist, dancing in the bedroom, singing like crazy because I'm frustrated about something? I do that. That's my escape. All right. I have a playlist. I call it Power of She. And I put it loud. My Alexa already knows. I just yell it out loud. Alexa raises the volume, puts it on. I go on with a couple songs. I dance along, and that's my escape. But one day, I only could listen to those songs. That's how it started. So what is our way to deal with that frustration, with that fear, and how we're going to deal with it? We have to figure it out together, right? Doesn't have to be me. It has to be a clinician that's willing to work with you. It doesn't have to be me. I'm saying me because it's me talking, but can be anyone, right? Anyone that's willing to sit down with you and figure out how am I going to do this. So the whole idea is that we create a plan that addresses all of you individually for your own needs that in adding a holistic approach, right? How are your meals? Are you really eating? Are you eating healthy? Are you even able to eat healthy? Because honestly, sometimes the stomach doesn't help, right? One thing is being able to have access to healthy food. And seriously, when you don't feel good, who wants to cook healthy, right? So is that a way that maybe we can get friends to chip in? Is that a way we can um, order a system that delivers healthy foods? And then there is, oh, but wait, there is the mast cell list, and then there is the FODMAP list, and then there is the, I'm left with the lettuce and water. How we manage that in a way that we find what works for you. It's great to say, oh, let's put you on a FODMAP diet, right? And yes, there is a place for everything. Okay, so there are those that need to be in a very strict diet. We can't say that there is no place for it. Everything has a place, but it doesn't fit everyone. So my modifications are completely different from Jen's modifications, which are completely different from your modifications if you have any. Um, I have a tolerance to certain foods that a lot of my patients don't have tolerance. It's figuring out what works for you, but keeping a open conversation with your clinician that's leading your case, which is the hardest part too. Because let's make a parenthesis here. Healthcare, the way it is very hard to treat a patient like us. And then we get in like that's second parenthesis, and I divert a lot, so you just have to put me back on track. We get to the doctor and we're like, we know they have 10 minutes, right? Because that's the healthcare. Get 10 minutes, 15 maybe, and certain practices. And we're like, we have all these things. When they say list your problem area, you circle the whole body. That's easy. It's one problem area per consult. I circle the body. My physician has actually, she's a friend of mine, so I can mess with her. She has a little sign on her desk that says, please only 2 complaints at time per consult in respect to other patients. And I'll say, I'll make it 1 for you. And I circle my body. And she's like, can you stop with that ever? It's like, no, I will. As long as you have that sign, I will circle my body. So the thing is, we don't have in the standard approach that we have in healthcare today. And this is not a physician's fault. It's the system's fault. Because the physicians and any healthcare, PT, physician, nurse practitioner, and the list goes on, we only have so much time when we are under insurance, unfortunately, because we need to be able to see everyone. We need to be able to deliver care for everyone. And then we, as patients, get there and we need to talk about everything that we're feeling. So it's like a horse race. And we're trying to put in everything and feeding as much as we can. And we do get them really lost because we're talking about a lot of things that in our language, and they're trying to keep track with as much as they can, but there's only so much each one of them can address. So it's frustrating for you, for me, for them. So how can we create a system where, again, everyone talks to everyone, where there is care coordination, where we look at your nutrition, where we are at, right? Where are you at with your, oh, you have certain symptoms. Where are you at with those exams that will point us whether you have a problem to that area or not? If you're having digestive issues, you're doing a great work doing your nutrition, right? You're cooking healthy, you're doing You're doing your organic veggies, right? All that, but you still don't feel good. You still have abdominal pain, or you still get bloated, or you still, where is the problem? Is there really a digestive issue? We need to rule it out. Is this a vagus nerve problem that is affecting your digestion? Is it a mast cell activation problem? Do we need to go that route? So we need someone that is looking at that presentation and saying, okay, let's start here. If this doesn't respond, let's go here. What is our next step? Let's refer you out, but not just refer you out to GI. Give a reasoning to that GI. If you cannot have someone that you know that understands that EDS, POTS and mast cell and etc., like I write essays to physicians, whether they read or not, I don't know. I really don't, but I do my part. But over the years, I have pulled physicians under my belt that I am able to communicate openly and say, hey, I'm sending you this person. This is the presentation. I'm sending you a detailed note. And I write a really long note that says, patient like this, like that, with this diagnosis, presenting with these symptoms and these other associated symptoms. This has been confirmed. This has been ruled out. Now I need you to help me with this, 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 this. I'm very specific. I'm not a physician. I'm not telling them what to do. And I say it at bottom. I'm relying on your expertise because there might be things that you know that I don't. But in my experience, this is what I have seen with these patients, right? So, and we have been successful in helping some of these patients to get the results they needed by pulling in the specialists they're willing to work with me and my team. And I wish really that we can get this everywhere, honestly, because that's my goal, having a clinic that we can really discuss cases. And I sometimes don't get I don't get feedback. If it's not for my patient to bring back their notes, sometimes I don't hear back. But for the mostly 80% of the physicians I work with now, or centers even that I send out, I do get notes back and telling me what they found, what they didn't. So in a nutshell, I think it's crucial that I understand as mainly a rehab person, okay? That I understand where you're at with if you have mast cell activation syndrome, where you're at with it. Are you being treated? Are you receiving medication the way it has to be? Are you have access? Do you need an appeal? Do you need me to help write something? Do we have all the tests that show what's going on with you? Is that surgical? Not everyone is a surgical candidate. And sometimes we really just wish we were because it fixes it, right? But sometimes it's way more complicated than just surgery. Sometimes we have gone so far low, been there, done that. We have gone so far low, so deconditioned, like it becomes a snowball. Now we just don't know anymore where is the real diagnosis symptoms and where is the deconditioning, because that you have POTS, you get the condition, you're way worse. You got mast cell, you got the condition, and you have POTS, lower even, right? And then you have joint hypermobility or EDS, and you never had dislocations, all of a sudden you start having them. And then now things don't even stay in place anymore. And then you stand, you feel all discombobulated, been there, done that, right? So how can we get you from that point that feels so hopeless at that point, right? How we can get you from there to a level little by little where we start cleaning out all those symptoms to see what is really left and say, oh, okay, you're stronger. We cleared a lot of this. Your mast cell is under control. Your POTS has improved. You're stronger, but you still have those symptoms that now show that you need. And I don't want to put specific diagnosis here. This is not what we are here for. I'm not going to say XYZ diagnosis in purpose, okay? That's when now we need that surgical procedure for whatever it is. It could be a GI issue, it could be a spine issue, it could be anything. The point is, how can we get you from that? Because not everything is really surgical in reality. And sometimes we just go so low because our emotional as well has gone so bad that we can see a way out. And all we want is find a way out. And we just want to grab to something really, really so strongly. And we believe. And sometimes as patients, and I say, I've been there. I've been there and I have thought many times, oh yeah, that's my only way out. And it wasn't, and sometimes going through the process, and remember, it's been 12 years for me. And I wasn't happy when I got to the 5-year mark. I was still in pain. I was still going to my training sessions with myself. Because I created my own protocols. I did things. I caused some more symptoms because I pushed. So everything that I do with any patient, I try with myself, right? Because I want to feel it. How does it feel in my body? And how does it feel if I didn't have the strength I have? So I kind of always looking that way, because not always it's going to be, it's easy to say, oh yeah, that feels great. But how does it feel for someone that has a shoulder instability and elbow instability, or even pain with gripping something, right? I have probably 80% dysfunction to my hands. Dislocated thumb chronically, can put it back, and my will, it comes right back out. It became my party trick now. Before I dislocated one way, now I dislocate the other way. Yay. I tape my finger, I brace my hand, and I do yoga. And yeah, there are certain things I can do, but I modify them. But I didn't let that stop me. I found a way to get through, right? So what do we need to do to get some level of satisfaction with that activity that we like? And hopefully that changes over time. Because I never thought I would be dancing 3 hours, much less line dancing or country swing dancing. I never even thought about that until August last year, when I'm like, I like country music. There's this country bar down the road. Why don't I check it out? And that's how it started. So, like, I found a new thing. So the thing is, again, how many times we need to modify it for you, for each one of you, to make it work for you. If you cannot sit on a bike to go through the POTS protocol, which is, I remember by heart, starts at 22 minutes or 25 minutes on a recumbent bike, but you cannot even sit up because your neck hurts, right? You cannot even pedal on the recumbent bike because your hip is clicking, your knees subluxing, right? That recumbent bike is not really friendly for hips and for knees. Been there, done that, because my hip used to sublux in the recumbent bike. And that's actually contraindicated for patients with hip labral tears. But then it's indicated for POTS. So how make this protocols talk, right? I know how we make this protocols talk. We don't call them protocols. We call them strategies, because we pull that strategy for each person and make it different, right? It's a puzzle. We are puzzles. And each one of us is different in shape and form, in personality, in beliefs, in symptoms. So we need little pieces that are different. And the puzzle that makes you doesn't make you. The pieces will be very different. The puzzle that makes me, the little pieces don't make anyone else. We're unique. So what is that is going to be needed on that POTS protocol to address you specifically. Because the exercises on the POTS protocol, the traditional ones out there, and I'm not going to name anything because everything has its place and has its importance and has helped a lot of people. So I'm not here to bash anything because everything has worked really well for a lot of people. But it doesn't work for everyone. So how can we make this work well for each one of you? I have had patients that started 10 minutes, repositioned the bike on the wall, and they actually paddle here, lying down, because they can't sit up. And then eventually we tilt with a wedge, and then eventually we sit up. Oh, now we got sitting. We're gonna put the bike under the feet, try the recumbent bike. Oops, labral tear, that doesn't work. How can we make this work? You know, in an upright bike when you need back support. Start figuring out things. Well, maybe that doesn't work. Maybe we need to go to the pool, right? How that pool can help that patient massaging the blood back up. Oh, but I can't swim. Oh, nobody said swimming. Swimming is a progression. How about getting in the water first? I think it's challenging enough to just change, get in the water, and then get out of the water. First, stay in the water 10 minutes and try to get out when gravity hits you on the head. It is challenging. Been there, done that, right? And then you have to change again. And that if you're lucky enough and you're not allergic to chlorine, me, thank God for saltwater pools because I cannot get into chlorine pools. I mean, I can. That doesn't stop me. I'm gonna be like scratching myself to a bleed. But so you see how can it be challenging? So if I listen to each story of each patient, so are you okay with the pool? You know, I don't know. Every time I go to the pool, I really get very itchy. Hmm. Well, maybe we need to, do you have access to a saltwater pool? Oh, you don't. Okay. Well, uh, let's try the recumbent bike. Oh, every time I do that, my hip hurts so bad. I can't do this. Like, oh, yeah, there is the history of labral tear. So are you okay with an upright? No, I can't because my spine and my neck. Okay. Can we get you on a elliptical? I just don't think I can do arms and legs yet. Okay. So start like exploring different things. Okay, let's put a bike under your feet. Oh, you can even sit up, lying down, bike on the wall, attachment. There's creativity for everything. Can't do the bike yet. We need to go through a different type of repetitive activity that will guide you and lead you to whatever that POTS is, the POTS program is. We'll get you there. So it's listening to each one. Is listening. So there's a lot of patients that will say, you know, I exercise. I did 5 exercises, 3 repetitions each, and I was down for 3 days. It just triggered every single symptoms that I never heard before and never had even before, or I felt so fatigued I couldn't participate even with my family, and I couldn't come down for dinner with my family. It happens. I heard that a lot. What is in there that's causing? Is that a metabolic disorder? Do we need a referral to further genetic testing? There is nothing there. No, I had that. There is nothing there. Oh, okay. So there is nothing there. So is that a tissue tolerance situation? Is that a nutritional issue? Each person is just so different. Why we listening to each one of us is like my key. I think when I listen to all of you and I gather everything, and I'll be very honest, sometimes you guys give me information that when because my whole work is not done when you guys finish, right? Then I sit down and I have to read all that and I have to interpret all that and I have to come up with a plan with all that. And sometimes I'm like, oh, what am I going to do with all this sentence? Which one am I going to start with? Because some of them I cannot address right away. Truly and honestly, we just don't know where to start. But working together. So each one of you is key. I truly believe that if each one of you leave here today and understand that you have to be a partner with your doctor, and hopefully your doctor understands that same thing, and you work together with your physician as a team, we all going to be able to get better results. So communicating is important. I always tell my patients, come on, tell me how you felt after the visit. I need to know, did you have digestive issues? Did you wake up beat up next day? Did you develop a headache? Were you able to exercise? What strategies did you learn? Because I don't want you dependent on me. I truly want you to go, I want to discharge you, really. I really don't like long projects. I get bored easily. I have ADHD. I get bored easily. So I really want to, my goal is that you learn strategies. What can you do? Like Jen said that right at the beginning. She said, I went to the pool and I did this. She knew what to do. Have you tried your own tricks before you freaked out that you had a symptom? Have said, okay, let me freak out a little. Okay, now that I freaked out, what did I learn? Breath work? I don't know. I learned that the only breath we took right in life was the very first one when we were born, and after that, we've been messing it up since. That's what I've been told by my breath coach. So does breath work for you? Does vagus nerve stimulation work for you? Maybe you are the meditation type of person. Maybe you're the person that goes outside, sit down and looks at the green and sit in among trees, and that works for you. Maybe you just need to get on the phone with someone. Maybe you just need to get in the tub with some Epsom salt. Maybe you get in the pool. Maybe what is your to-go activity? Maybe you put the music loud and you dance along if you can, like I do. That's my thing now. But before, I could not even do it, anything like that. So exhaust your tricks. I want you to be independent. That's why we are here. I don't believe in maintenance. I don't want to maintain anyone sick, right? I'm going to put you on a maintenance program. Let's just stay sick together. Okay? I believe that how can we make you better and how can you enjoy life? And not maintain, but make small snail improvements every month or every year or if you focus on what else is next, have I addressed, full on, have I addressed my trauma fully yet? Maybe not. Have I addressed all my potential yet? Maybe not. Do I mess up and eat things I shouldn't? Oh, yeah. But I plan things because I learned to plan things. Like, you know what? I'm going to eat something I can't eat. So I'm going to be good for the next 2 days so I can have that thing. And then I am going to have symptoms because I am going for that ice cream bucket because it's not enough to eat a little bit. It has to be the bucket directly with the spoon, right? And then everything comes down to, yeah, really bad. So then the next 2 days, I know I have to do a certain regimen so I can uh, names, name whatever you want. I can feel better. Do I really need to do something that makes me feel bad? How is what is the exchange here, right? So learning your tools, what are the best tools for you is critical. And speaking up, like, I know we have tried this medication, or I know we have tried this exercise, or I know we have tried, this didn't work for me. I've been to PT before. That didn't work. So I hear that all the time, by the way. I've been to PT, that didn't work. Okay, what did you do that did not work? That's someone I'm interested. What have you done in PT that didn't work? Well, I would go there, then I had pelvic tilts, then every time I did this, then it would hurt here, and then they had me slunge, then they had me they put ice, electrical stimulation, ice. It's important for me to know what didn't work because I'm not going to give you that. And when you, like, someone tells me, when I did this movement, it made me worse. I'm interested to know what other movements that are similar to that one that make you worse. So if you're telling me, for example, let's make it easier. If you're telling me a tuck pelvis or a pelvic tilt makes you have shooting pains, I will ask you, are you able to reach down to your foot without having shooting pains? Are you able to bring your leg up? It's the same movement. See? Right? Bending down. That is telling me something. So now I'm going to go that route. Okay, what is being tension, traction, pull that can be causing those symptoms? Am I going to give you an exercise that leads you to that? No. I'm going to maybe reverse that pattern. Because now I'm going to ask you, well, when you went the other way, how did that feel? When you stand up, how did it feel? When you reach overhead, how that feel? That's telling me a different pattern. I'm looking at your functionality. You're going to get to the clinic. If you're expecting me to do muscle strength, and by the way, if you do show specific symptoms that grant a neurological evaluation, of course, I will go do neurotesting. Okay, that's important. But if you are showing me signs of functional, more of the functional issues, and I will go and see how you move, how you walk. Walk for me. Let me see how you walk. I'm watching when you're talking to me how you carry your body, how you carry your head, how you sit up. If you're like, you know, going around the chair, and the person that's like nervous and like been there, done that too. So no judgment here. But what is your body language? Your body language is important. And I think that if we observe, and that's what I tell my therapist, if we observe you guys carefully, we know where to start. If we observe eye contact, body language, mast cell reactions when you ask certain questions. I've seen so many. Like you ask the person, how was that? I don't know. I'll use my experience because I don't like to use anyone else's experience. When someone would ask me, how was your labor and delivery? Red like a lobster, because it was a traumatizing experience. So I would have a histamine reaction as soon as you ask me about that. Now you can talk, I can talk hours of that. Maybe I'll kind of have a little hiccup here and there when I remember really, but I don't have a reaction. But for someone that's going through it at the moment, watching, so let it be. If you feel like you're in front of your practitioner and they ask you a question that makes you feel like crying, cry. For God's sake, let it out. Let it out. People need to know that you're hurting. Because and keeping emotions in is the worst you can do. That's horrible. Because you just internalize all this and just makes it even worse. So when you're at the clinic, we make sure that we listen and watch you. We make sure that we see you moving on the chair, moving around the clinic, how many times you actually need to adjust your body, um, what type of clothing you're even wearing. Are you comfortable in your own? What are you wearing? What are your tools? I want to know everything, right? Um, so let me make sure I keep track because I can talk hours here. Um, So, and I want to give you guys like about 30 minutes at the end-ish so we can actually have a conversation because I don't want to be a monologue and just kind of want to hear as well. So what I put together over the years has been more of a observing people move, finding where the limitations are, matching them with their emotions, with their psychological state, with their trauma level support system, everything, and trying to work this along in parallel because we are a person, not a one specific system. We have brought in breath work. We have brought in, and that doesn't mean needs to be done only with one practitioner. If you find someone that is a breath worker, I don't know if there's such thing, but maybe there is a title like that, breath worker. I think so, right? I don't know if I'm using the right term, but if you find someone that's a breath worker that has a certification in whatever breath that works for you, go for it. If you found an acupuncturist that works well for you, please explore that. If you found a massage therapist, body worker, neuromuscular massage therapy that works for you, please explore that. Because we will not know our potential until we have potential of recovery until we have explored all or exhausted all our sources. And honestly, I still do a lot of self-care. I go for a massage therapy session with a well-versed manual therapist weekly. I meditate daily. In between patients, I take 5 minutes so I can get myself out of this experience that I just finished, refresh into the next one. And then at the end of the day, I don't take it home. Ibuprofens every night because I was afraid to feel pain. It wasn't until my urologist said, "Are you out of your mind? You've been doing this for 2 freaking years nonstop." And he's like, "Do you have pain?" I was like, "No, but I'm afraid to have pain." He's like, "Stop it." And I knew I had to. I just needed him to kind of whip me on the butt and tell me I had to stop. I was afraid to have pain. And I didn't have pain when I stopped. I was doing it because I thought I needed to do one thing. So are we dependent on an idea of something that's helping us? We already have conquered that and we don't need it anymore. We need it at a certain moment of our lives. We need it at a certain activity. When I go running, I wear my specific compressions. I love that it's called CWX. They are compression for professional athletes because I hate using grandma compression. No way that I was going to put those compression pantyhose as ugly thing. I wanted something fun, something that made me feel athletic again. And they're really cool because they have the kinesio taping pattern that goes like, right? They make you feel powerful. And they're so good. I have had patients that put them on and said, "Oh my God, I can walk with this thing," because they do muscle activation. They're expensive, but they're worth every penny. I still run on those. Okay. Not because I'm afraid, but because I have three hip surgeries and I want to make sure that my hips don't go anywhere else other than where I am planning to go. Can go that way. I still wear my upper body compression when I feel that I need a little more support on that day. I still wake up in the morning and I meditate. I still use my vagus nerve stimulator, right? Because it feels good. I relax. I feel refreshed. So it's self-care. Self-care is not necessary for someone that's sick. Self-care, everyone should play. Everyone should do self-care, right? We don't need to get sick to be able to do self-care. So just throwing out there a couple tools so you guys kind of write down if you want, if you don't know about those. I use my compression toppings tops are Tommy Copper shoulder shirt, which I like because they kind of hug me and pull me back. They have a sports bra as well that I like because I live in Florida. They have long sleeves because for those that blood pool, you will need something longer initially. There is also another brand called Align Med. Align Med also has the kinesiotaping kind of style, the abdominal compression. The pants were already spoken for the ladies, and there's for men. CWX has for men as well. And there's a trick to CWX that a lot of people tell me, "Are you sure you want me to cut them?" Some people will feel like because it's a very thin waistband, and for those that have abdominal bloating, sometimes it might not be the best when we are bloated. So what I had to do on my initial pants, I don't have to do it anymore, was to cut a V right in between the string because it has a string to tight. So I cut a V, get some of the elastic tension out, and then it fitted my pregnant belly from eating things I should. And then it worked. I always run, walk, cycle, dance with proper inserts because I need inserts. Now, if you bought a pair of shoes that is already for people that have flat feet, don't overkill and add another insert to it until someone has looked at your foot and said, you're still pronating, still supinating, whatever that is. We need, because it ends up, I have seen a lot of people in the clinic that happens. They get like a Brooks glycerin, and then they get that very heavy insert that the podiatrist gave. Thank God for podiatrists, they do a great job. But then you guys put it all together because you're told you have to wear it in every shoe. No one explains these things to you. And I make sure that you guys understands this. You have a shoe that is already correcting, and then you put something that's correcting. Now you went from being here to being here. Now you're actually overcorrecting, and that's also bad. So if you don't have a PT, go to your runner store that you bought the shoe and ask them to look at you on the treadmill. Hey, because those people are trained to look, they're not clinicians, but they do a pretty good job in telling you if you're overcorrecting. But, obviously you want to look at more than the foot. Correcting the foot is not enough for someone that has joint instability, hypermobility, laxity, wobbly hips, bendy body syndrome. Let's not label anything, right? You want to make sure that everything above the chain is also strong. So are your hips strong enough to keep you balanced on your feet? Because you correct the foot is not enough. I love the idea that if you correct the foot, everything up above the chain will work. But if your hips are not strong enough, it's not going to be enough. You're going to need to see a PT that understands understands your needs and your body, that looks at you as a functional being, not as a joint. So it's not about, are you here for hip pain? And that's what ends up happening with a lot of clinicians, because when we come in, I say we because I've been there, done that. You say like, well, it's my shoulders, my knee, it's my hip, and they're like, oh, whoa, whoa, 2 joints at a time if they're close to each other. But if it's your neck and your foot, I can treat on the same session. You're going to have to finish your protocol for the foot, and then you come back for the neck. Right? But it's a one body. It's one person. And if we look at the myofascial lines, if we look at the anatomy, muscles will react to positions, right? So an example, this was a case that I had in clinic. A distance runner that developed, it's not an EDS patient. I want to use that one in purpose. because it's easier to see. We have so many things sometimes that's hard to see, but this one is easy. She went to PT, OT, MRI, CTs, etc., because she would develop shoulder blade pain to the right side about mile 3 of her run. Every time she ran, she changed shoes, she changed where she was running, she changed the time of the day even because she thought she was running in a time that she was more tired. Nothing would improve her condition. I didn't find it very easy though. I'm not bragging about that. It was difficult to find actually. Not difficult, but it was puzzling because she had a whole history that didn't improve in many ways. Turns out that it was her diagonal line, right shoulder, left glute. Her left glute was weak. So every time when she would get about mile 3 or 4, she would have to crank this arm and this side body more to compensate for the left glute that was getting weaker and tired. So she would start cramping up here. So once we looked at her hips, we looked at her walking, we put her on the treadmill, made her get tired, which by the way, treadmill is not my favorite for any one of us. We are not moving, the floor is. So it's a head-on collision, or I should say a heel-on collision against the ground every time. For us, is not the best. So when we put her as an athlete on the treadmill and we had her run the 2, 3 miles, 4 miles, when she started developing the symptom, then we could see the fault. So by saying that, what I'm trying to say is we need to look at each one of us, clinicians, PTs, at the clinic, we look at each one of us very independently, or very uniquely as how each one moves. Because your weakness is different than your weakness, and your limitations, and the tightness that we are experiencing, it improves with stretching. It feels good stretching when we are so tight, but doesn't mean that that bounces right back, because we have to stabilize somehow. Okay, so that's what I'm so what we do, so what we are doing now, I guess, is creating protocols that are specific for each one of you. We use suspension training as a form of unweighting the body, finding the tissue fault, finding the muscles that are not working, and rebalancing it again. Work with your body's tolerance, your tissue tolerance, your specific needs. And if I say anything again, it's going to be repetitive. I think right now, let me see. So I'm just going to tell you guys what I'm kind of coming up. We are doing a couple things with expanding a little bit and doing a couple things with different institutes. So now, has anyone heard of Polestar Pilates? So I have associated with Brent Anderson at Polestar Pilates, and we are actually creating a whole course for clinicians and for Pilates instructors to actually work with bendy bodies. So all this therapists or this Pilates instructors will be able to actually understand a little more the needs of each one of us, or participate more in the treatment of us, because we need a whole comprehensive approach. I'm also working with Herman Wallace, which is a pelvic floor institute, is educational institute, and we are creating a pelvic floor course for clinicians to assist them to understand better our needs as pelvic floor patients. Because guess what? Our pelvic floors are holding us together. So it's more likely to be tight on most of us. It's going to be, and if we make it let go, then we create more instability. So how can we balance this whole thing, right? Make the pelvic floor go and let go and allow you to go to the bathroom better, stabilize the hips, improve your pelvic floor health, improve many aspects of the life of everyone. So we're working with them on that as well. So I've been invited. I'm honored to have been invited by the Ehlers-Danlos Society to speak at the conference in July. And we're going to be talking exactly about exercise modifications for patients. The one in Philadelphia. Yeah. And that's going to be exactly about exercise modifications for us. How we break it down so tiny that meets the needs of those that cannot do a full movement. And I think that's the biggest trait that we need to understand as clinicians. And how we modify when there is spots. How we modify when there is mast cell activation syndrome so we don't flare someone. Right? How we modify in many ways. I think when we talk about those that want to get pregnant as well, I think it's something to talk about. How do we prepare those women that want to go through pregnancy so they actually can deliver safely with all the things that we already can develop and deliver, right? But how can our bodies be safer? That's another approach that we need to look at. That's another thing to be talked about. I mean, there's small things that make a big difference in our bodies. I try to put the basics, but the important points, along with my colleague Marcia Perretto from University of Miami. We wrote a small book that goes straight to the point, that gives timelines, that assesses each one of you, has a little questionnaire, so we find where to put each one of you. So give some guidance to PTs. But it's by far is just a prototype of something bigger that we are going to be releasing further. So I guess I think I spoke too much. I want to hear. I want to talk to you guys now. So I know that there will be people online that might be throwing some questions. So if there are any questions, Patricia will let me know and I will let you guys know what the question is and I'll answer. But let's start here. Does anyone wants to say anything, ask anything? First victim? Don't make me pull one. So what is the cause of the migraine? That will be my first question for that patient. Have you explored, and is this a true migraine or yes, exactly. Is this a true migraine or a headache? Is it coming because, is this true due to craniocervical instability, cervical hypermobility? Is it coming from just overstrained or cervical spine or cervicogenic headache? Going through working with the patient and addressing what we are finding many times clears the headaches. And if it doesn't clear the headache, we need to explore other routes. So do we need to refer out? Do we need further imaging? But we first start working with the musculoskeletal aspect to see what is there. I like to say it's like a college party. You cannot mop the floor until you pick up all the stuff that's there, like paper cups and furniture and pieces of whatever is on the floor. We start picking up the bigger items and figuring out what is in there. And then if it doesn't improve, we see what is left and what could be the possible causes. But yes, migraines, I think, is probably 80% of the complaints, migraines and headaches for all patients. And we have seen good improvement once we go through the strategies that we utilize, because they can be coming for many reasons. We need to figure out how to clear that, and we've been successful with it. So there are different ways that we work with people. Some people will come to us and spend a couple days with us, and we put together a program that they're going to carry on with their clinician. Some will come to us, work with us in person, and then continue online. Others will, there's and Melissa can say because we work together on cases, right? We contribute together, and it's like I can consult on the case, but in person online as consulting and support to the care team, even discussing with physicians outside town, discussing with other PTs, massage therapists. I mean, whoever, you're acupuncturist, because I do dry needling, so I can say, hey, we're looking at this, can you do anything with your needles for this, and how that affects your lines of energy? Then I defer it to them. I don't know anything about that. Mm. And I think each patient changes over time, right? So every time I'm working in contributing or consulting in a case, and that patient comes back 3 months later, it's a new patient. If the patient is following the program, that patient changes. If you put in the work, things will change. And if they're not changing, we need to look into what is missing. Because it's not because you're just broken and it's not fixing. Oh, sorry, you're broken. That's not working for you. Don't know how to fix it. No, why it's not working for you is the why behind it and what we have to do to change. But putting in the work, following what it has to be done, following with other new referrals that we need to do, it's always going to have good results. And it's different because when I see the person again, it's actually, I like that better because when I see someone that I haven't seen in a while, I can see better. We kind of get blinded sometimes when we see all the time. And when we take a break and we see again, we're like, oh, that wasn't there before. And I like that because I get to see it's, I guess I have the joy of being able to see those things. Oh yeah. Okay, so the red cord is a suspension training on steroids. It's a big metal track in the ceiling that has three tracks and another pulley system that does rotations. So what I learned over time is that the traditional approach for patients with CCI would not work. Trying to go ahead and press down on a neck and give you isometrics only might not be the way. Might help here and there, it might help in certain things, but that's it. Indirect work to the neck is the one that people respond better. So the connection of the pelvic floor with that craniocervical is huge. With red cord, I get to clean out the movement. And I get to see what happens when the person is out of gravity. I get to see the quality of that movement. I get to see the movement unloaded. And then some of you might say, well, but then you're taking my proprioception off because gravity is giving me proprioception. True, but that still doesn't mean you move efficiently because if you did, you wouldn't have neck pain, right? So let's take away that gravity and let's see how you purely move and where you're compensating. So I get to suspend a whole body if I want. I can literally suspend a whole person on it, or I can suspend partially, or I can suspend the cervical spine only, take the resistance of the pillow, and literally have that cervical spine move the way I need. So now I get to guide the movement. Now I get to segmentally guide that rotation. So you're not only moving from your skull, or I don't even touch the skull. I just suspend you there, and I create proprioception through vibration. I create muscle activation through gentle presses in certain positions. And I don't even touch the neck sometimes, and I go all the way away from it because some of us just don't tolerate the neck to be touched so early. So that has been key. I think red cord overall has been the key for not only the neck, though, it has been the key for a lot of patients. And not only also red cord, but also the thought of the progression from supine to side lying to recumbent to sitting to kneeling. Where is that person need to go before they go back up, standing, sitting, walking, moving dynamically? That's what, so the red cord allows me also in supine to have you do like snow angels is one of my favorite movements for neuromuscular reeducation. And you can do a snow angel with no gravity on red cord. And literally you can add any directional movement, PNF, to retrain your neuromuscular system. Yeah, the red cord is like one of my favorites. And then I use a lot of the principles from yoga. No, yoga is not a stretch. Yoga is actually about strength. You go further if number one, you have the length, number two, you have the strength. Yoga is not about resting on ligaments. Yoga is about the power of holding yourself in a static position and moving through the positions on your breath. I purely rehab myself mainly with yoga and suspension training. And then after I added Pilates. How old is the child? Okay. So if it was my child, and I like to say that, I always say people, if I go to a physician, go to him, because that's where I'm going. And that's what believe me, that's the best one because I go to the best. It was my child. I have a daughter with EDS and has gone through a period of disability because of gastric issues as well, GI problems. My daughter, I knew she was bendy from early age, right? So no impact activities. I did not let her go through gymnastics, not because gymnastics is bad, but because the way they boot camp everything you put your child in. I didn't let her do ballet because I have seen enough patients that literally have been put through, and well, literally being a figure skater. I had a Russian coach, which was the closest you can get to a Russian ballet teacher or instructor, right? Where they just care that you be pushed to the limit of the joints and overtrained, things like that. So I wouldn't let that child do gymnastics, ballet. I would not let do any contact sports. I would encourage exercise. I would encourage maybe activities like that would generate first a sense of normalcy, like playing outside, playing ball with friends, running. Like they have like those gyms for kids. They're very light and climbing and doing very organic activities. That's what I would put my child. That's what I did with my child. We would take her to these gyms for kids where they had like climb things and go down things and down in tubes and she went on until like 12 years old on that. And that's, I think my daughter's physically, she's actually quite well. She's quite strong. And she continued, then she adopted the gym and she now does yoga. Shocker. She does yoga. She does not like Pilates. I tried. She does not like it. She likes yoga. And she does not go beyond her range of motion. So yeah, raising a child with hypermobility would be protecting their joints, but yet letting them move organically and feel normal beyond anything. Anyone else? Yes. Well, every time you have an extra diagnosis, it makes things a little more challenging, but I don't focus on the diagnosis. I don't treat a diagnosis. I treat a person, right? So, what are your needs specifically? What are your challenges? What are your goals? And some are a little more challenging, some are just standard patients, some even excel. I have a lot of patients with lupus, others with rheumatoid arthritis, others with let me see if I remember what else I have in clinic right now. I know I have a couple with lupus and rheumatoid arthritis. And I have not seen much of a difference, to be honest with you. When they are well balanced and well treated, the medication is finally, they found the balance for the medication. I have not seen. Of course, we have to be more protective of the joints or more protective of the system as a whole. But I don't like to treat anyone. I don't like to treat anyone based on their diagnosis. I like to treat you as a person and what your needs are. Because I don't believe that we should allow our labels to define us. That diagnosis is just giving us some red flags to what to protect our bodies with and what are maybe some hiccups that we have. That's kind of high. I like to think that as our superpower. Okay, I have this. This is the medication. This is what I have to be careful with. Done. I don't give power to a diagnosis. I respect by all means, but I prefer to treat you as a person. Anyone else? Full of arthritis. Okay. So we look at EDS as having three phases: the hypermobile phase, the pain phase, and the stiff phase. But these are not cut lines, right? They all blend. So then we're hypermobile, bendy kid. Like I've been the bendy kid, I had a lot of fun made out of me because I was weird. I think I still am, just different weird now. Um, so then that phase blends in when we get into puberty and we have pain. So it's hypermobile pain phase. Then we go from the hypermobile pain to hypermobile to stiff pain or pain stiff. And then we start stiffening up. And then it seems like things get better. Not really better, because now we have arthritis pain, right? But things get better. They're not, we're like, I used to dislocate my shoulder, but now I don't. I used to dislocate it, now I don't. We are more prone, and we need to look at this as research though, but I call it me search based on watching my patients. I see that as my patients age, they become stiffer, their symptoms improve in a certain way, but they develop arthritis earlier. When my surgeon, my hand surgeon, took an x-ray of my hands, he literally walked in the room and he's like, oh, that's not your x-ray, that's a 70-year-old lady's hand. And I just look at it. He's a friend of mine, so he knows he can mess with me, but I'm like, kill you. It was my hand. It didn't look good. And I was actually 38 when he said that joke. I'm 52 now. So yes, we will be the wear and tear is a lot more. So I believe that we will develop arthritis earlier. If there is a paper out there that proves that, I haven't looked at, but it just makes sense based on clinical observation, not my opinion. Clinical observation points out that, and if that person that, if I, this is now my opinion, my educated opinion on this. If we have a child or a daughter or a son that is hypermobile and mom remembers that she was bendy, but now she's as stiff as a board, likely that arthritis that mom has being stiff as a board is coming from the early arthritis that has now progressed so much that she's not bendy anymore, but she has advanced arthritis compared to someone at her age. Hypothesis for a study. Addressing it. So it's about, so I think as a society, we grow up and we stop exercising and maintaining our bodies. I think the way we have evolved nowadays, we don't have enough physical activity. We don't exercise enough. And if we go back in time and we would look at like my ex-husband's grandpa, he was 96. He would get up at 5 a.m., go outside, deal with his chickens. He lived like in the mountains in Puerto Rico. Deal with his chickens and plant his plants and deal with his animals. And he was outdoors. He was working. He was 96. The man was a picture of health, right? Get a 96-year-old in the city, right? It's a very different picture. So I think we evolved as society. We have so many things easy, and we stop doing so much of the physical activity. We sit in a box to drive around, right? We don't walk. I literally, I leave 0.2 miles from a grocery store. In my defense, I can carry my grocery bags. When I am just picking up one thing, I actually walk, but most of the time I'm driving, right? And we all do that. We will drive to places that we could have walked. Oh, but it's a mile away. Yeah, but we could have walked a mile. We used to walk. I lived in a farm. I used to walk 5 miles to the town, to the city, up and down hills. Yeah. As we evolved, we stopped exercising. We stopped doing things outside. We don't have to work so hard for anything anymore. We don't have to plant. We don't have to pick up potatoes anymore. We don't have to walk distances. We don't have to milk your cow to get the milk. And not that we should be doing. It's fun though, I done. So I think as we evolve, we stop physical activity. As we get older, we stop even more. So I feel like if we continue to keep physical activity as part of our lives on daily basis, we would be in a better place with the arthritis, because we would, number one, would be stronger altogether. Muscle strength at the end helps with stabilizing joints. Physical activity improves pain. Exercise improves pain, improves your well-being, your mindset. It's a way to escape from all the craziness sometimes we have going on at work. But we put so many things in front of it. Like, I had to go to the gym, but then, I just had to clean the house. I had to pick up the kids. I had to do this. I had to do, and yes, sometimes we don't have to. But can we maybe get up half an hour early? Can we maybe just give the kids a little snack and put them to do something? Can we make the kids join us? Can we go for walks every day and take the family? Can we get out of the screen some and move a little more? When we can, obviously, not all of us can. That we have to start somewhere, but yes, it's difficult to start. But yeah, I think that if we were more physically active overall, if we kept our bodies better over a lifetime, we would be better off with less. Yes. Hypothesis for research. Maybe there is one that I don't know about. So there are support groups, right? There are several support groups. So the EDS Society hosts a lot of them, but I have a beef with support groups sometimes because there is a lot of sickness talk in the groups too. And I feel like we need an empowerment group. So I wasn't going to say it, but I will, because now it makes me do it a little harder. I'll have to do it then. So I've been working on launching what's called the empowerment group. Um, it's not to talk about, of course, we're going to talk about symptoms and things here and there, but it's about empowering you from those symptoms up, not to maintain you keep sick type of thing. But yeah, it gets lonely. Support groups are the closest we have right now to keep you connected. They're Facebook groups. Exactly. And you took the words out of my mouth. And Mhm. So for those of you that are here, and for those that are online, um, you guys are gonna be my pilot group for the empowerment group, because I have to start somewhere. And so you guys are gonna be my pilot to give me some feedback and control. But I believe that we need a group like that where, like Jen just said, I identify better with a PT that has EDS. How can we discuss that as a group, and how can we help that other person that is in the group that does not have access to a PT that has EDS or does not have a good one and doesn't want or has had a bad experience, how can we help that person? How can we empower that person? I think that's what it is. Because like you said, Facebook groups end up being a lot of people complaining. Yeah. And I have gone on Facebook groups and said, someone would put something, and I'm like, I want to help. So I say, hey, this symptom can be this, this, and this. Have you had this and this and this? There's this physician, da, da, da. And I am giving tools. And then 3 days later, they post the same post. And they don't even acknowledge. I'm like, are you complaining only? You don't want a solution? You just want attention? Or you're not ready for that solution? Are you not ready? Because been there, done that. So anything I say, I'm not saying because I heard of someone or I'm directing to anyone. I've been there and done that. Once we identify with the diagnosis and we find comfort in knowing what we have, sometimes we just find that it's safe to just stay there. I was there. I was like, oh, I have EDS. Can do that. I have EDS. Oh, no, I have EDS. For me, I identify so much with the diagnosis that it was comfortable to stay there. And yeah, how can we make it so small that she's not going to have a reaction? That's my job as her clinician. Oh, you did that and it caused that? Okay, what was that? What was happening around you that day? Because you might be blaming that exercise or that food, but did you have a stress situation? Did you just didn't sleep well? Did you have been in contact with a virus? Was that a coincidence? Can we try this again? Can we push again? Do we cut it back? That's when I say communication with your clinician is such a key, and how can we help? Figuring out, because you are your own puzzle. I cannot tell you how you have to be. That's why I said the round hole does not fit every single round peg. Even the round pegs don't fit in the same round hole. So much less the triangular peg is going to fit on that protocol. So having a PT that has EDS doesn't mean, and I have heard this, and that's why I'm going to say, I have heard people saying, I don't want to go to a PT that has EDS because they figured out for themselves and now they want to fix me with the way they fix themselves. That doesn't work because we all have EDS differently. Some of us don't have EDS. Guess what? In my clinic, I have patients with POTS and mast cell activation syndrome from a TB test. And then they were like, oh, by the way, I feel like I'm so bendy now. And we're like, were you bendy before? No, I never remember being. It's like, how did that affect your connective tissue? We have been looking at it now. How someone that got a COVID vaccine, got COVID, TB test, HPV vaccine, all of a sudden develop first what spots, which now I look and say, that looks like mast cell, and I'm not immunologist, so, but I'm saying this because I'm part of the masterminds group, and they are saying we are seeing this, and then they're like, you know what? There is this acquired connective tissue disorder thing now that people are like more bendy. So, like checking what else is going on in your life. Did they check everything possible? Did they check for mercury poisoning, for any viruses that you could have reactivated in your body? I would start with allergy immunology, but someone that is mast cell versed, not just any allergy immunology. And next step, neuroimmunology. And if the ones you have locally has not helped, I would go the direction of Dr. Ann Maitland in New York. I would go Anne, A-N-N-E, Maitland, M-A-I-T-L-A-N-D, if I spell right, Maitland. There is a waiting list. There's a waiting list everywhere, but I tell my patients, I know this is the first day of the rest of your life, but if you can get better sooner than later, it's a lot better. So if you have to get into an airplane and fly to see someone, do that. Get into a telehealth conversation first to make sure that they are going to be able to help you so you don't waste your ticket. But gather as much information as you can locally, all blood work you can locally, and fly to see someone. Oh, but it's out of pocket. Well, can we do a GoFundMe? Can we get some friends to pitch in? Hey, it's my birthday. Can anyone? I'm collecting money to go see my allergist in New York. I don't know. But don't resort to only the local because sometimes that is not enough. I have patients flying all over the United States, to be honest with you. But I contact them and I say, I have this case. Can I send to you? This is what I'm seeing. Because I don't want anyone to be disappointed to fly all the way far and find out that that physician couldn't help. But it's about figuring out what's going on systemically as well. It's not only like, let's pound you with exercise and hope you get stronger. Because that definitely there is an underlying situation going on there. One thing is you exercise and you got overtired, been there, done that. Okay. The other thing is exercising, releasing enough histamine in your body to the point that you have a mast cell reaction. And you have this underlying mast cell situation going on for a while now that is responsible for your POTS as well, which there is a correlation. So how we level systemically that, how we fix that, and that I defer to the ones that know that better. I'm just a resource to help guide you to the right ones. But like figure that part out and then figure out how we can get you better in parallel with all that treatment. Like today, I had to hop on an urgent telehealth. I pulled a physician out of my resources. My patient from Florida that was in another state, she was having a crisis. I was able to pull that physician, got on the telehealth with them. We got her medicated. We got the orders out. And fingers crossed, that will be what she needed. But if she's not, we have plan B already. But we were able to, that's what I like doing. I like to pull resources and care coordinate because I have, with this 12 years, learned not only to rehab patients, which I fail just like anyone else, right? We all have our limitations. This is a teamwork. I don't make you better. We together work towards getting you better. But also helping you find the resources for the rest of the things that I cannot help you with. Because I would be amiss if I didn't. Anyone else?
Dr. Perretto,
Patrice, anyone?
can you hear me?
Yes.
Okay. Yeah, we have a lot of questions.
A lot of questions.
So can we take a couple of them? You have time?
Yes, definitely. Mm-hmm.
So this
I'll read out loud the questions for you guys so you know the answers. Mm-hmm.
is from an anonymous attendee. They want to know, how do you best support a friend or a family member who has EDS?
How you best support a family member who has EDS. Listening, helping them with what their needs, with their needs in the household. helping find resources when you cannot help them directly yourself. Because sometimes we cannot do everything, right? We work and we have that family member that has a need. So what can we have friends come in? Can we create a schedule of friends? One friend comes on Monday, another friend comes on Tuesday, you pitch in on Wednesdays. Do you need groceries? Who is picking up groceries today? Oh, you have a doctor's appointment. Who is going to take that person to a doctor's appointment? Hey, I just need to talk. I need to, I need to be listened today. I'm frustrated with my symptoms. Get on the phone with them. Let them cry, let them speak, take them somewhere, take them for something fun too. It's not all about the negatives, it's about the positives. Let's go out to dinner. It's being there. It's just being there. Being there when you don't know what to say, you don't say anything. You're just there. Just knowing that someone is sitting beside me made a huge difference for me, even if they didn't know what to say. But I just knew there was someone there.
Next
Good?
question. As a patient, how do you handle the ups and downs of EDS? I make progress, but I also have lots of setbacks. How do I stay motivated to keep moving forward?
So as a patient, how do I manage setbacks? Right? Just talking about a little bit about that. I make progress and then I have a setback. How do you stay motivated to moving forward when this is happening? I think setbacks are going to be part of everything. I think we need to look at, so I always tell people before you get better, you're gonna get a lot of setbacks. The secret is observing how long those setbacks are lasting. Are those setbacks now happening maybe less often or lasting less? Are you knowing how to use your tools and actually waking up really crappy this morning, but instead being crappy for the next 2 days, you did X, Y, Z and you feel better? Or learning that activity you did needs to be cut back until you build that tolerance. I have done that a million times to myself where I would overdo and then I would be 2 days, 3 days down. And then I realized, okay, I cannot do that much. For me to dance 3 hours took me a lot of 15 minutes that caused me 3 days of setback. And then eventually it became 20 minutes, it became 30 minutes. Eventually I was able to stay late, eventually. And that doesn't need to be in a major activity like that. It can be as simple as I did 10 minutes of biking because I'm told to do the POTS protocol, and now I feel wiped out. So then you do 5. You start with 5. You start with 2 repetitions, and if you have a setback, you go down to 1. But it's knowing that if you did 2 on the following day, you already made progress because you did it 50% more than you did before. Right? If you did 1 repetition one day and 3 days later you're able to do 2 repetitions, that's 50% more. So it's going to be disappointing. It's going to be discouraging, but knowing that if you persist, the results will come. And if they're not coming, you need to revisit the approach with your healthcare provider because you're not broken. It's just the approach is not the right one for you. How can we change it to make it better? Next.
This is from Sarah Montgomery. How can you increase strength in your joints to improve stability? With numerous dislocates and subluxations in my knees, elbows, back, and shoulders, I find pain increasing in my attempts to strengthen my body.
So how someone increases stability to the joints? How someone increases stability to the joints in order to get stronger without injury?
Well, with numerous dislocates and subluxations.
In someone that has numerous dislocations, subluxations, she finds it difficult to improve her strength because she keeps dislocating, subluxing. Again, it goes back to working with the right professional. It goes back to, are you recruiting the right muscles? Are you breaking down the exercise to a level that you can perform it safely before you move on to the next level? Are you wearing enough supportive garments, not braces, unless it's extremely necessary, garments that give you proprioceptive input? So it's a very broad answer, I understand, but having the right professional to really look at you and make sure that you are using the right muscles. Because we have, as bendy bodies, we have a master's degree in compensating movements and getting God knows what muscles involved when we should be using a specific one. So yes, that would be working with the correct professional to help you identify if you're even recruiting the right muscles.
Next question from Itzy Yamas. Lower back pain from working at a desk all day, but standing desks are a no-go because of POTS. What can be done?
Lower back pain from working on sitting on a desk all day, but standing desks are a no-go because of POTS. Have she tried alternating positions every 10 to 15 minutes from up to seated? Has she tried moving? I can't stand for too long in one place. I will start moving my feet under the desk. Even when I'm sitting, I'm actually pumping my ankles. If I'm standing, I'm moving constantly. I alternate positions every 15 to 20 minutes. I go from a seated to standing, taking breaks when necessary and possible. It's changing positions that helps us. It's not staying on the same position. I know sometimes it's difficult, so an alarm clock is the best thing, but moving is the key. Static positions do not help us.
Thank
Next,
you.
I think we pretty much down to the end, so let's do, how much more do I have there, Jen? I have a couple more questions here. 5 minutes? Okay, I'm fine with it. I'm fine too. I just want to make sure everyone is okay. All right, next.
This is from Melissa Cole. She wants to know what vagus nerve stimulator you use.
Okay. What vagus nerve stimulator I use Pulsero. And Pulsero is 50% off. No, I don't get any kickbacks. It's 50% off in honor to Mental Health Month. So it's from 500 and something to 230 something. Really, really, really good. By the way, I don't recommend anything that I have not tried myself and has worked. I don't waste my time in telling people resources that don't work. If it stimulates your vagus nerve, so it improves your fight or flight. Oh, it's electrical stimulation. It's a little electrical stimulation, but you don't have to be holding like the older ones. It's like a headphone on the neck. Yeah. Next.
Considering the importance of the holistic approach and many different medications and procedures needed, why doesn't insurance cover more of the costs for people with these challenges being discussed?
The million-dollar question. Why doesn't, considering the holistic needs of patients that present with what we do, why doesn't insurance cover? Simple and plain, we cost money to insurance companies and they are not interested in spending money on us. The physicians don't get paid enough. We don't get enough benefits. They keep the money. Simple and plain. There is no interest. I fight all the time with insurance companies to get coverage for patients, trying to explain that if they gave the patient that infusion 3 times a week, that patient will not be going to the emergency room 3 times a month and spending 10 grand in each admission. So they would spend 1,000 a month with the patient. They would save 30 grand a month with the patient. Well, they don't care. It's too logical, exactly. Yeah, there is no, I think we as patients over time putting pressure might be able to change this. It When you talk money to insurance companies, when your clinician writes a letter of medical necessity and tells them clear and plain that this patient is going to continue to go to the emergency room, or this patient is going to continue to cost them this much money, and it's going to increase, the cost is going to increase over time because the complications are going to increase, the chances that they approve are higher. Because the current model of healthcare system is not preventative. It's a sick care system. It's not a healthcare system. So there is no interest in getting you better. To use in a medical necessity letter is literally, it depends on who you are getting that is analyzing the case, because it always depends on the person that's doing the case analysis. And they are going to tell you, and it's pretty much saying, if you take care of this person now, you're going to save a ton of money. That's all they want. If they are going to save money, they're happy. If they're not going to save money, they don't care. As much as they I make very clear point that there will be a substantial saving of insurance resources if that person is treated. But it's really depending on each healthcare provider how they want to write it. Unfortunately, it is. They will do peer-to-peers, and if the healthcare provider is strong enough on that conversation, they might be able to get message across. We have gotten the message across with a lot of patients, and we also have not, and we have had to go through appeals. Mm-hmm. Mm-hmm. Yeah. Mhm. Yeah. Which they will win you by tiring you up. They want you to give up, and a lot of people, unfortunately, will give up from the appeals because they're like, I'm done. I just don't have the energy to keep appealing. Mhm. Exactly. It's not their child, it's not their mother, it's not their family member. Mhm. Mm. Yeah. Yeah, no, a letter needs to be substantial, needs to explain what the diagnosis is, the complications of that diagnosis, what are the implications for the cost and healthcare if that patient is not taken care, and then automatically like finishing up with saying, you guys are gonna save money. Yeah. I can't go there. Yeah. And but sometimes it's not even the out-of-network benefit that's being denied, is the in-network benefit that they decide that you have no right to have. Is that patient that needs an IVIG infusion and they say, no, we decide that you don't need that. Well, what are you a physician? Are you an EDS physician? Are you an immunologist, a mast cell specialist? Yeah, there will be the name of the reviewer, and then you can go after and mm-mm. Mm-hmm. We're gonna tire you up, and then you give up, and then we save the money. Mm-hmm. Mm-hmm. Most of the backup documentation will be there, and they will say you didn't send the documentation and on the initial denial. Yes, correct. Disappointing, frustrating, but don't give up. Next,
One last question before our time.
last question.
Um, from Melissa, what kind of projects are you working on with Mayo Clinic and Johns Hopkins?
With Mayo Clinic, so what type of projects I'm working with Mayo Clinic and Johns Hopkins? With Mayo Clinic, I am a clinician advisor with the EDS clinic. We collaborate in the care of patients to give continuity to what they have been diagnosed. And I also support them with further referring out patients that have not received full the full workup that was necessary to fully diagnose them with more comorbidities. With Johns Hopkins, we also associate and refer. We meet weekly. I meet weekly with Johns Hopkins Dysautonomia Clinic, and we also have a couple other physicians from different parts of the United States to which we discuss the newest research in dysautonomia, the approach. I work with the Dysautonomia International on developing more awareness and research. And right now they're on the phase of physician education for diagnosis of POTS. And then next year we're looking into allied health education as well.
Thank you. We want to thank our online audience for being here tonight. We appreciate everyone tuning in. And if there are any more questions, we will send an email. Dr. Perretto will address more individual questions as she gets around to it, gets back to Florida. But we appreciate you being here, and we will contact you when we do this again.
All right. Thank you, everyone. Thank you for logging in. Bye-bye.